This presentation was created by Tyler Corder and Zach Stepp, and we will be discussing the topic of alcoholism. The outline for our presentation is going to consist of a few different factors. First, we're going to define alcoholism. We're going to look at risk factors, who is predisposed to this and why. We're going to look at some of the pathophysiology around effects from alcohol abuse. We're going to look at how it's diagnosed, treatment options, what alcohol overdose looks like, along with withdrawal symptoms that may be seen in the clinical setting. And then we're going to cover some anesthesia considerations for these types of patients. We're going to present a case study, and then we're going to have 10 questions at the end just to double check some of the knowledge. So first, let's start by defining what alcoholism is. It's a chronic disease whose development and manifestations are influenced by genetic, psychosocial, and environmental factors. This is conjunction with a long-term intake of alcohol. This is very common in the U.S. and impacts many Americans. Up to 10 million are reported to be impacted by this. It's also estimated that 50% of individuals experiencing alcohol, drug, or mental health disorders will have 2 or more psychiatric disorders in their lifetime. Female psychiatric patients have a higher comorbidity related to alcohol dependence. Medical problems associated with alcoholism are discussed on the next slide, but they are many and they range the entire spectrum of the organ systems within the body, as you can see from the picture here on the right. Alcoholism is commonly overlooked in the elderly as well, whether because they have some memory loss issues or other chronic issues that they're dealing with, but a lot of times that can be overlooked in that population. Here is a screenshot of a table from Stolting that we use to kind of encompass the wide range of secondary problems related to alcoholism. Again, lots of issues arise from alcoholism. They can result in widespread problems within the body. Alcoholism and its effects can alter our anesthesia, and as anesthesia providers, we must be cognizant of how to manage these patients since they can deteriorate quickly and all body systems can be affected. So you can see on this table, it's got CNS effects ranging from everything from psychiatric disorders that we know are very common with alcoholics, nutritional disorders, and going to cardiovascular effects, GI and hepatic effects, skin and musculoskeletal effects, endocrine and metabolic effects, along with hematologic effects. And many of these are going to be represented in some of the signs and symptoms of alcoholism and chronic alcohol abuse that we'll be discussing in a little bit. We wanted to break down some of the pathophysiology behind the signs and symptoms of alcoholism throughout the organ systems. So first, we'll kind of start with the neuro effects that are potentiated by GABA. And GABA, we know, is the major inhibitory neurotransmitter in the CNS. And when the GABA receptor is activated, the chloride ion conductance is increased, causing hyperpolarization of the cell membrane and inhibiting depolarization. Alcohol increases GABA-mediated chloride conductance, and this has a synergistic effect with alcohol, benzodiazepines, and barbiturates, which also allows for a cross-tolerance and cross-dependence to occur. Another neurologic effect is hepatic encephalopathy. This is a neuropsychiatric dysfunction caused by significant liver disease, which again can be caused by chronic alcohol use. Hepatic encephalopathy is graded on a scale of 1 to 4, ranging from mild changes in behavior to coma and unresponsiveness to painful stimuli. The patient may also present asterixis, which is a flapping tremor of the hands when the wrist is extended. The hepatic effects of chronic alcohol use can be seen in the picture up on the top right of the slide in the stages of liver damage, the worst being cirrhosis. And histologically, cirrhosis is characterized by fibrous deposition that causes distortion of normal hepatic architecture. This fibrosis disrupts the sinusoids and other vascular structures, causing increased resistance to intrahepatic blood flow. This causes portal hypertension. Portal hypertension caused by cirrhosis produces splenomegaly, formation of varices, ascites, gastropathy, and hepatorenal syndrome. GI and pancreatitis issues include varices, which again caused by portal hypertension, where the veins dilate to accommodate the increase in collateral blood flow. This increased pressure in the thin-walled vessels increases the risk of spontaneous rupture and thus variceal bleeding. This can be massive and can lead to death if not promptly treated. Ascites, which is accumulation of fluid in the peritoneal cavity due again to portal hypertension, hypoalbuminemia, and salt and water retention. These are just a few of the major effects seen with chronic alcohol abuse. There are many more that were listed on the previous slide, but these are some of the major ones we would see in the clinical setting. Risk factors for alcoholism include male gender and family history. And the family history that could play with this is irrelevant of biologic or adoptive family history. So it can happen in both situations, which highlights the importance of environmental factors in the development of alcohol abuse. And then as far as diagnosis of this disease, there are a few ways to detect it. However, it's usually more subjective and requires the provider or us to be suspicious that the disorder may be happening. You can grab breath or blood supply level alcohol tests for acute intoxication. However, chronic abuse is usually more readily identified by complications, i.e. the things that we discussed in the last slide. Malnutrition is one of these as well, possibly making hypoglycemia an issue perioperatively. Routine lab tests can provide some insight. Increased RBCs, increased liver enzymes, specifically gamma glutamyltransferase, as well as possible liver dysfunction.
Alcoholism treatment can start with total abstinence from alcohol. Obviously, this is the first line, is to just simply avoid alcohol altogether. Another option is disulfiram administration. This causes the patient to have flushing, vertigo, diaphoresis, and nausea and vomiting if alcohol is consumed while taking this drug. The goal is actually to deter the patient from actually drinking and to avoid those pretty uncomfortable side effects. The mechanism of action for this medication is it prevents complete metabolism of alcohol. And this actually results in a accumulation of acetaldehyde, and that's what causes those unpleasant side effects. Now, this can actually pose an issue because the patient could simply just stop taking the disulfiram. So unfortunately, with this medication, long-term compliance is actually pretty poor. Another issue with the medication is it's contraindicated in pregnancy and any cardiac, renal, or hepatic dysfunction. Another issue that can happen is hypotension, but this is best treated with a direct-acting sympathomimetic like phenylephrine. Another treatment for alcoholism is psychiatric counseling. So with psychiatric counseling, the patient can discuss triggers for their alcohol consumption. They can also work through possible coexisting psychiatric issues that might need to be addressing. And also another benefit is it gives the patient someone to talk to through their hopeful journey towards the end goal, which is abstinence from alcohol. In alcohol overdose, we first must discuss an overdose criteria. In non-alcoholics, a blood level of 25 milligrams a deciliter is associated with impaired cognition, but as well as impaired coordination. Intoxication generally starts at a blood level of 80 to 100 milligrams a deciliter. Now, greater than 100 milligrams a deciliter, we can begin to see signs of vestibular, but as well as cerebellar dysfunction. Some examples of this can include nystagmus, dysarthria, but as well as ataxia. Unfortunately, another issue that can occur with the alcohol overdose is an autonomic nervous system dysfunction. Now, this can generally result in a hypotension, hypothermia, stupor, and the patient can very well go into a coma. Long-term tolerance from prolonged excessive alcohol intake can allow the alcoholic to remain sober, or at least appear sober, despite a potentially fatal blood alcohol concentration. We generally attribute a fatal blood alcohol concentration of greater than 500 milligrams a deciliter. Now, this is due to respiratory depression. Now, some key aspects of alcohol overdose is the fact that alcohol is a central nervous system depressant, and with rapid consumption of large amounts of alcohol can lead to respiratory depression. Now, in any life-threatening alcohol overdose, treatment generally starts with ventilation and securing the airway, which is most important. Another issue that can occur is hypoglycemia, which can be rather significant. This generally occurs because alcoholism is often associated with food deprivation. Another issue we have to keep in mind is other central nervous system depressants are commonly consumed with alcohol. Now, they generally can work synergistically to induce respiratory depression or just cause apnea. So when there's a physiologic dependence on alcohol, this can produce a withdrawal symptom whenever alcohol is either discontinued or there's a rather significant decrease in the intake of alcohol. The earliest and most common signs of alcohol withdrawal Now, in Wernicke-Korsakoff syndrome, it's important to note that this is not an alcohol withdrawal syndrome. However, it does show that the patient has or has had a history of physical dependence on alcohol. Now, on the MRI on the right-hand side, there's a normal brain on the left, and on the right, there's the Wernicke-Korsakoff syndrome. As you can see inside the yellow circle on the right-hand side, there's a graying, which is periaqueductal lesions, and this is generally contributed to the Wernicke encephalopathy. Two key components of this syndrome is Wernicke encephalopathy and Korsakoff psychosis. Now, both of these are actually due to a lack of thiamine intake. And as we know, decreased thiamine intake is part of that food deprivation that occurs with alcoholism. Wernicke encephalopathy is a loss of neurons in the brain Now, this actually basically occurs from brain cells having a lack of nutrition, thus results in cell death. Korsakoff psychosis is a loss of memory, and this can result in both anterograde but as well as retrograde amnesia. This syndrome essentially is due to a lack of thiamine. Thiamine is essential for carbohydrate metabolism, and without it, carbohydrates cannot be metabolized correctly. Signs and symptoms generally include confusion, ataxia, drowsiness, nystagmus, as well as peripheral polyneuropathy. Treatment starts with IV thiamine. IV is done first since many of these patients who present with this syndrome are often confused, they're drowsy, so unfortunately there's a risk for aspiration, so it's best to just use IV. With improvement in cognition, oral consumption can be resumed, but this usually can take days. When treating this patient for hypoglycemia, you must give thiamine before the glucose. If you give glucose before, the cells can't use the glucose you just gave. The cells actually need the thiamine to use the glucose. So giving the glucose without the thiamine, it's like giving them more to work with that they can't even use. Now for some anesthesia considerations. It's important to review that GABA is the primary inhibitory neurotransmitter in the central nervous system. Activation causes an increase in the chloride conductance and hyperpolarizes the cell. This, of course, inhibits the action potential propagation. Alcohol also activates and makes sensitive this GABA receptor, but the issue is the fact that many other anesthetic medications also work on this receptor. This can cause a synergistic increase in anesthesia effect when combined with the use of benzodiazepines, barbiturates, or even if the patient is acutely intoxicated. So discussed previously, disulfiram is often used to assist with the rehabilitation of alcoholism. It's very important to gather this information in the pre-op evaluation, the fact that the patient is actually on this medication, because it's linked to increased sedation, hepatotoxicity from that acetaldehyde accumulation. Another issue that can happen is what appears to be an unexplained hypotension. Now, this is due to an inadequate norepinephrine storage because disulfiram actually inhibits dopamine beta hydroxylase. Another issue that can happen is the fact that disulfiram metabolism inhibits other medications that we commonly give in anesthesia. With regional anesthesia effect, it's important to avoid alcohol-containing solutions. Prevention of alcohol withdrawal syndrome is vital. If it occurs, it can change a rather benign surgical course into a very life-threatening one. Now, this is because the patient could have a seizure, they could very well aspirate, delirium, or cardiovascular collapse can occur. Prevention in alcohol withdrawal syndrome perioperatively is vital. Alcohol withdrawal is characterized by a sudden rebound in the GABA system. Because chronic use of alcohol can suppress the neurotransmitter GABA, the absence of alcohol postoperatively can cause an unopposed sudden rebound in the GABA system. For an elective surgery, this can be avoided by tapering alcohol over a certain period of time prior to the surgery. It's also important to note that alcohol infusion can also be used to treat withdrawal, but it's losing popularity. General treatment is benzodiazepines, antipsychotics such as haloperidol, anticonvulsants, baclofen, barbiturates, clonidine, trazodone, vitamins, and magnesium are also used in the perioperative treatment of alcohol withdrawal. It's also important to note that alcohol has been associated with a higher surgical morbidity as well as a higher mortality risk. Now, to continue with additional anesthesia considerations, it's important to note that in our text it states that illicit substance use in patients in the pre-op is more accurately identified using a computer-based self-assessment rather than the actual anesthesia provider. Now, this can gain some highlight to the fact that there's a very critical need for anesthesia providers to conduct a very thorough preoperative evaluation on each and every patient. It's really important to be clued in and really focus in on possible signs of alcohol withdrawal, dependence, or acute intoxication. This may very well include family members in the discussion to gain a very complete picture. Of course, history of alcohol abuse or dependence are common issues that present for surgical emergencies or traumas. Both alcohol and mental disorders play an important role in traumatic injuries. Examples include motor vehicle accidents, fights, falls, hunting accidents, as well as self-inflicted injuries such as gunshot wounds. Surgical evaluation is often needed for cirrhosis, gastrointestinal cancers, peptic ulcer disease, as well as pancreatitis. Basically, alcohol is a major risk factor leading up to the need for surgery. The anesthetic effects on these patients depends on the overall amount of alcohol ingested, relative affinity of the anesthetic for particular hepatic microsomal enzymes, as well as the severity of the underlying liver disease. Patients with chronic alcohol intake may need an increased requirement of anesthetic agents, whereas patients with acute alcohol intoxication usually requires less anesthetic. It's also important to note that patients with alcoholism can often have a higher requirement for analgesics postoperatively. The need for an increased need is usually associated with the higher opiate tolerance. It's also important to note that alcohol-dependent patients are more likely to leave the hospital prematurely against medical advice, as well as less likely to adhere to post-discharge instructions, follow medication regimens, as well as attend follow-up visits after the surgery. Lastly, alcohol crosses the placenta and can result in a decreased infant birth weight. High blood alcohol concentrations of the mother, usually over 150 milligrams a deciliter, may lead to fetal alcohol syndrome. This syndrome is characterized by craniofacial malformations, growth retardation, as well as intellectual disability. So for our case study, we have a 61-year-old male patient that presents with a left femur fracture and is scheduled for an open reduction and internal fixation. The patient has a history of chronic alcoholism, and to prepare for the surgery, the patient has abstained from drinking alcohol for 50 hours. Some preoperative measures for alcohol withdrawal has been put in place, such as aspiration prophylaxis. He's also been given lorazepam 2 milligrams IV before bedtime the night before the surgery, and as well as 2 hours prior to surgery. During the preoperative interview, the interviewer observed no signs or any kind of symptoms of alcohol withdrawal. The anesthetic plan for this surgery was to receive a spinal block. And to help with the placement of the spinal block, the anesthetic team had opted to perform a fascia iliaca block with 0.25% bupivacaine 30 minutes prior to placing the spinal block. Well, about 20 minutes after the initial incision was made during the surgery, the patient started presenting what seemed to be some alcohol withdrawal symptoms, such as agitation, hypertension, as well as tachycardia. So the issue with this instance occurring with this patient is the fact that the patient has a history of alcoholism and is showing some signs of classic alcohol withdrawal symptoms. However, the patient also received the fascia iliaca block with the bupivacaine, which is a aminoamide local anesthetic, and there must be a differential diagnosis of local anesthetic toxicity. In local anesthetic toxicity, it can occur when a aminoamide anesthetic becomes systemic. And the signs and symptoms of local anesthetic toxicity mimic that of alcohol withdrawal syndrome, the agitation, hypertension, and tachycardia. But the majority of these signs and symptoms usually occur within about 1 minute after the aminoamide anesthetic injection. So this patient was treated for the alcohol withdrawal syndrome instead of the local anesthetic toxicity. In order to manage the hypertension and tachycardia, a esmolol drip was initiated, and for the agitation, 2 milligrams IV midazolam as well as a propofol drip was started. Following the surgery, a ICU admission was implemented, and luckily the surgery was actually able to be completed without any further complications. And while the patient was admitted to the ICU, a psychiatric consult was requested and ended up resulting in confirmation of alcohol withdrawal syndrome. So this example is rather important for us as anesthesia providers. And since the patient had 50 hours of abstinence of alcohol, it's outside that window of the 24 to 36 hours whenever alcohol withdrawal syndromes is the most pronounced. Us anesthesia providers must be able to rather quickly work through what signs and symptoms the patient presents with, additional medical history that could be pertinent to the issue, and as well as be able to rather swiftly narrow down to the appropriate treatments based on what's most likely occurring. And unfortunately, this patient had the alcohol withdrawal syndrome right in the middle of the surgery, probably the worst possible time. With this patient, there was the alcohol withdrawal syndrome versus the local anesthetic toxicity. And given the patient's, again, history of alcoholism, 50-hour abstinence from alcohol consumption, and the fact that the complication did not occur within a short period of time after the bupivacaine injection, treatment was geared towards the alcohol withdrawal syndrome. Now, if the patient was actually having a local anesthetic toxicity, a 20% lipid emulsion would have needed to be given. So this highlights again that anesthesia providers need to be very cognizant and be able to really hone in on signs and symptoms of alcohol withdrawal syndrome, acute alcohol toxicity, in order to be able to really swiftly differentiate between a few differential diagnoses and be able to select the best treatment for whatever the patient's presenting with. So in summary, alcoholism is a chronic lifelong disease with physiological effects are commonly seen throughout the body, and several very well might be life-threatening. And as anesthesia providers, we should be very cognizant on the synergistic effects of alcohol and the several medications that we usually give perioperatively. Treatment, rehabilitation, and abstinence are mainstays of the recovery, and every patient's story, symptoms, and outcomes can be very different. And to highlight the case study, similar diagnosis can mimic alcohol withdrawal syndrome, such as the local anesthetic toxicity. So again, as anesthesia providers, we must be able to differentiate between a couple complications that could be going on and be able to pick which treatment option is most appropriate for what's going on with the patient.
Now to do a knowledge check, we have 10 questions coming up, all that were discussed within our presentation to kind of test the knowledge that you've gained. Question number 1. Which of the following is a risk factor for alcoholism? A, male gender, B, female gender, C, family history, or D, A and C? The correct answer for this, according to Stolting's text, is primary risk factors are male gender and family history. So the correct answer would be D, A and C. Question number 2. Which of the following is a common sign of liver disease caused from chronic alcohol abuse? A, varices, B, cirrhosis, C, portal hypertension, D, all of the above. And the correct answer for this one is going to be D, all of the above are signs of chronic liver disease. Question number 3 for our knowledge check is diagnosis of alcoholism is typically subjective. Even so, what's the most important factor aiding in diagnosis? A, breath or blood alcohol level tests. B, jaundice of skin or sclera. C, high degree of suspicion. or D, routine lab work? And while all of these have some level of correctness and aid in the diagnosis of chronic alcohol abuse, the most correct answer would be C here, a high degree of suspicion. So the provider needs to be diligent in monitoring for signs and symptoms during the pre-op evaluation, as other tests may not be as helpful or as readily assessed or seen as clearly. And you may not look for some of these other signs and symptoms if you aren't suspecting that there might be some alcohol abuse issues. Question number 4. When do alcohol withdrawal symptoms most often begin? Or when are we going to be seeing these signs and symptoms? A, 12 to 24 hours postoperatively. B, 10 hours of NPO status. C, 30 minutes after induction. Or D, 6 to 8 hours after decrease in alcohol blood level. And the correct answer for this one is going to be D, 6 to 8 hours after decrease in blood level is when the symptoms start and become most pronounced at 24 to 36 hours. Question number 5. Which neurotransmitter is primarily responsible for synergistic anesthetic effects with alcohol and other medications? A, glycine. B, disulfiram. C, GABA. D, glutamate. Correct answer for this is going to be C, GABA, which has some of those synergistic effects with multiple drugs working at the similar receptor. Question number 6. Which factor will increase the anesthetic requirement? A, chronic alcohol intake. B, hypothermia. C, acute alcohol intake. D, gender. For this one, the correct answer is going to be chronic alcohol intake.
So question 7. What vitamin deficiency contributes to Wernicke-Korsakoff syndrome? Is it A, niacin, B, thiamine, C, folic acid, or D, tocopherol? Well, the correct answer is B, thiamine. You have to remember that with Wernicke-Korsakoff syndrome, it's a lack of thiamine. So unfortunately that occurs with the food deprivation aspect of alcoholism. So with the thiamine deficiency, it results in the Wernicke encephalopathy and the Korsakoff psychosis. All right, so for question 8, disulfiram inhibits which enzyme leading to a depletion of norepinephrine? Is it A, dopamine decarboxylase, B, 18-hydroxylase, C, beta-hydroxylase, or D, tyrosine hydroxylase? The correct answer is C, beta-hydroxylase. This can cause what seems to be an unexplained drop in the blood pressure. And in our text, the Hines book states that the use of phenylephrine allows for a more predictable response to blood pressure. All right, so for question 9, intoxication is defined by having a blood alcohol level of at least what? Is it A, 50 milligrams a deciliter, B, 70 milligrams a deciliter, C, 25 milligrams a deciliter, or D, 80 milligrams a deciliter? The correct answer is D, 80 milligrams a deciliter. This is what starts the definition of intoxication generally. Remember also, 25 milligrams a deciliter can be when non-alcoholics can start to show signs of decreased cognition, but as well as decreased coordination. Okay, for the last question, question 10, which hematological effect is not commonly associated with alcoholism? Is it A, leukopenia, B, hyperproteinemia, C, thrombocytopenia, or D, anemia? The correct answer is B, hyperproteinemia. All the other ones are commonly seen in alcoholism, but hyperproteinemia is not. In fact, it'd actually be hypoproteinemia because with alcoholism and liver disease, there's a decrease in albumin because the albumin is made exclusively in the liver. So if there's liver damage, you're going to have low albumin levels.
Here you can see a list of our references used to create this PowerPoint directly from the textbooks used in this course, along with a couple other resources for the case study and to support our evidence.